in which etanercept, infliximab in 3 to 10 mg per day at 2, 6, 10 and 14 week, then every 8 week. Then adalimumab, golimumab, certolizumab, and obviously, as you all know, TNF inhibitors, they are lethal for reactivation of the tuberculosis and the infections. So before starting of TNF inhibitors, we always go for you can say tuberculosis workup if patient is already having or had TB. So we have to rule out before starting of these. Then we can go for abatacept if patient is not responding to TNF inhibitors. Then rituximab can be given. It's basically a monoclonal antibody against anti-CD20 B cells, which can cause persistent hypogammaglobulinemia. Then if patient is not responding to all these biological and synthetic DMARDs, we can go for interleukin-6 inhibitors, which includes tocilizumab and sarilumab. The side effect of these are it can cause GIT perforations. So these were all for the disease. Now if the disease like RA has caused some complications, we can go for supportive treatment. You can say if patient is having anemia, we can go for iron or erythropoietin. If patient has developed osteoporosis, we can recommend him or her vitamin D, calcium, bisphosphonates. If patient is having vasculitis, we can go for glucocorticoids or cyclophosphamide along with it. And if patient is having long-term amyloidosis, long-term RA leading to amyloidosis, we can start with other immunosuppressants like chlorambucil. And even if patient has developed due to methotrexate or due to the RA itself, pulmonary interstitial pneumonitis and pulmonary fibrosis, we can go for the start the treatment for fibrosis. Antifibrotic drugs can be done if long-term, if persistent still, we can go for lung transplant. Then after medical surgical involvement, at a surgical treatment, how we can deal it if patient is having any involvement of median nerve leading to carpal tunnel syndrome, we can get decompression of the carpal tunnel, we can get arthroplasties of the knee and hip joint, arthrotomies of the metatarsal joints, then there can be tendon release and transfers, and there can be arthrodesis. So prognosis and mortality, mostly the mortality in RA is due to cardiovascular disease. And after months to years, the patient is not taking the treatment, deformities are ultimately going to develop. There are certain prognostic factors which if are present, it means there is grave prognosis. If there is early functional involvement, there's high ESR, CRP, rheumatoid factor and anti-CCP levels if the patient is male. If there are rheumatoid nodules present, if the disease is insidious, that is gradual in onset, and there is any evidence of erosion. So that's all for the treatment. I would like you to know about how we give these treatment, and say that is most important for the pain relief we are giving. Along with that, I already told you as a bridging therapy we give with the steroids. Then according to the physician, if there is mild disease, physician may start with only a single treatment like methotrexate or HCQ, or it can start, or he or she can start with a double treatment like methotrexate plus HCQ. In the second, if the patient is not responding after 3 months, still not there is no improvement in the disease, and DAS score is not less than 2.3, then you can go for triple therapy. You can change from methotrexate, sulfasalazine and HCQ. If patient not responding to triple therapy, after again 3 months, you can add JAK2 inhibitors or you can add anti-TNF inhibitors. If patient still not, then you can shift to biological DMARDs. If there is no response, you can go for rituximab, tocilizumab, tofacitinib, abatacept. If in certain points there are antibodies developed against certain biological DMARDs, so we have to change those biological DMARDs into another biological DMARDs. And along with this, there is important thing how we deal RA in pregnancy. So 2 drugs which are contraindicated, I already told you, methotrexate and leflunomide. They are contraindicated, they are teratogenic. 6 months methotrexate, 2 years leflunomide. And in pregnancy, for the patient should be in remission, she can take painkillers, and only Panadol, and NSAIDs can be taken only in second trimester. Steroids can be given, HCQ and sulfasalazine can be given. And in biological DMARDs, infliximab can be given up till only 16 weeks, and certolizumab is safe for it. So that's all for today. Thank you so much.